Hello and welcome back to Instagram Live with Intimate Rose. I'm Dr. Amanda Olson. I'll be joined today by Andrea Martin, nurse practitioner extraordinaire. She specializes in hormone care and she will be joining us to talk about hormone testing, labs, what are the truths, what do we learn from it, what do we do with that information, what we can and cannot test for. So she'll be popping in. If you have any questions along the way, please don't hesitate to put them in the chat. And we are continuing on talking about different issues that come up in menopause. So if you have a topic that we have not yet covered, please don't hesitate to put it in the chat or DM us here at Intimate Rose. Andrea's popping in. Good morning.
Good afternoon.
I'm way back here in Pacific Standard and you are way ahead of us eating lunch at Eastern Standard.
We're only 1 minute into the afternoon, so we were in the morning together for quite a bit. Welcome to the future.
I love that. You sent me a welcome to the future at midnight on New Year's, and that made my day. It gave me so much hope. You were already there. It was way back here at 9 p.m. getting ready for bed.
You were in 2024, and I was already like, girl, we're in 2025 doing cool things.
And now I've caught up.
AKA nothing.
So today is super spicy. It's time for Andy and Mindy Talk Vaginas, and today we are very specifically talking about hormones and blood panels and labs and testing and truths and myths, because there's dialogue about, are labs valid? What do we know? Tell us.
This is a contentious topic, and it can be frustrating for patients and providers alike. I think some of it comes from the fact that in general, you don't actually need labs to diagnose if somebody's in perimenopause or menopause for your average bear. But what happens is women go to their OBGYN or whatever, and they say, I want my labs tested, and they say that's not necessary. But then the conversation stops there, and that's just it. So, they have a list of this is happening, and I have this symptom, and this and that, and it's just, nope. And then that's where it dies. So I think this is where, obviously, that's not a good approach to things. So to kind of explain why these labs are a little controversial and when they're useful, when they're not. If I have a woman that comes to me and she's 45 and she's having hot flushes and not sleeping well and this and that, pretty safe to assume that she's probably in perimenopause. Or if I have a woman who's 52 and said my period stopped 2 years ago and, I've been having vaginal dryness and this and that, you put two and two together, it's probably not a far jump to say like, oh, it's probably menopausal. What happens specifically in perimenopause is that labs can be super variable all over the place. I could test your labs at 8 o'clock, and then I could test them at 12 o'clock, and you're going to be getting different numbers. And that can be frustrating, one, if you're like someone who does get labs, and you're like, I'm having terrible hot flashes, and then your estrogen comes back as like totally normal. And they're like, well, you don't need estrogen. It was fine. It's like, well, yeah, if you checked it like 2 hours later, it was in the toilet. So that's where, we don't want to rely so much on the labs. We want to look at the person and look at their story. Same thing with postmenopause. If someone's curious what their estrogen is, I can probably tell you what your estrogen is. It sucks. It's in you're not making much. However, if patients want to know, sometimes they just like to see numbers. I'm kind of that way myself. Like I'm like, well, what is my estrogen? I want to know. We do the labs and we look. I just forewarn, especially in perimenopause, it might not be that like validating answer that you'll get like, see, I knew it. I knew something was wrong. It might just be like, oh, in that moment, your estrogen was perfect, but we're not going to show you. It also can be, again, I'm talking about like standard average person where you're like, okay, this all makes sense. But of course, there's other situations where we absolutely need labs. Like of course, menopause does not, menopause isn't always the cause of everything. You might have other conditions that are causing certain symptoms, like, with trouble sleeping, hot flashes, fatigue, things like that. So if there's other things we're concerned about, or if the picture doesn't match perfectly, we'll want labs to look at that. If you're kind of younger than we would expect for menopause, we want to use labs to confirm, because you shouldn't be in, if you're less than 40, that's concerning. We want to figure out what's going on and confirm. Also, sometimes patients, it can be tricky, like, is this, if they're having irregular periods, is this menopause or is this PCOS that's causing, your irregular periods? So that might be a time. And then, of course, you have patients that can't rely on their periods to give them, the data. So we say your period is kind of like another vital sign. So if you don't have a uterus, or you have an IUD, or you've had an ablation, sometimes we might use labs in that scenario. But again, if you're in the age range and the symptoms match, don't necessarily need to do labs, but it's an option.
I have a lot of patients who use their oral birth control and they use the cycling method to where that they don't have a period.
Mm-hmm.
So they plow right on through. And a question that I've gotten in the past is how do those labs look in that particular case? And does that even give valid information?
Good question. No, it does not. You can't test your labs when you're on birth control pills. So it's suppressing ovulation. It's also the estrogen in birth control pills isn't the same exact estrogen that we would measure in blood. So we would measure estradiol in blood, and in most birth controls, it's like ethinyl estradiol. So it wouldn't even show up. The number is kind of meaningless. So yeah, in those cases, you would have to go off the birth control for a few weeks and then, test blood work. But again, if they're of an age that makes sense and they're on birth control, but they're having, hot flashes, this and that, it's fair to just be like, all right, let's just transition you right over to hormone therapy. We don't have to be like, all right, we're going to make everything worse for 4 weeks, get your blood work, hope that proves it to us, and then we can start you on hormone therapy. There is an easier way to do it.
That makes perfect sense.
Yeah.
So when someone comes in and they ask for those labs, you provide this sort of education,
Mm-hmm.
and it doesn't necessarily change your plan of care because you're basing it more on the symptoms of the person sitting in front of you and their holistic medical presentation.
Yeah, absolutely. It's rare that I feel like I want labs, or that we get labs and I'm like, oh, that's not what I was expecting. And kind of to give you an idea of what some of these labs might be. The biggest one we use to kind of diagnose menopause is something called FSH, or follicle stimulating hormone. And this is a hormone that your brain sends out to your ovaries, and it's kind of like telling them, like, let's produce some follicles and then produce some estrogen. So when you start to go through perimenopause and you're not getting, you're not producing as much estrogen, your brain is like, hello, let's send out some more. It's like, let's produce some estrogen. So it sends out more FSH to kind of yell down at your ovaries. And as, it's not getting that feedback loop, the FSH goes up and up. But again, perimenopause can be super variable. It might be low one day, it might be high another day. I even get nervous sometimes telling somebody for sure. Like, we say the way to like definitively diagnose menopause is if you've had an elevated FSH. Of course, this depends on what lab you use, who tells. In general, greater than 20, greater than 30, somewhere around there. If it's been elevated 2 times and you separate it by a 6-week period. I have a few patients, one in particular, she's a pharmacist and loves data. So she loves labs. They make her happy. We make little graphs. She looks at it. We've been like testing her FSH, and there's been times where it's been low and it's been high, and I'm like, you would have technically met the criteria for menopause at some points, but like it went down again, it went up again. In general, after you've had your final menstrual period, that's just going to shoot up and kind of stay up. But that's a big hormone that we look at. some people look at LH. I don't need it. That's a luteinizing hormone. It kind of works with FSH to regulate ovulation. It can be elevated in menopause and things, but I don't think it's as reliable as FSH. Another big one we look at is your estrogen level, so estradiol. The normal, quote unquote, normal levels in perimenopause vary widely. It can go from, 50 to 500, and any of that can be normal, because I think sometimes people forget. We think perimenopause, menopause, my estrogen just goes, but it doesn't. It goes whoop, 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 whoop. It does whatever the hell it wants, and that's some of the fun of perimenopause. So again, another time where kind of checking your estrogen can be misleading, because you might get like some ridiculously high number. One area where I will check estrogen levels, if say someone comes in, they've got symptoms, they've got hot flashes, we put them on hormone therapy, and they're not really feeling a difference. We adjust the dose, and they're like, this is doing nothing. Then I'm like, let's check levels. Maybe you're not absorbing it, especially for like patches, things like that. There are occasions where the labs are going to tell us, like, you're given the medicine, but it's just not translating. It's not absorbing. So that's why this patient isn't feeling better. Progesterone is a lab that some people look at. Again, I don't care at this point in my life. I always say there's going to be more data that comes out, and someday I'll be like, oh God, I said the stupidest thing. There's no progesterone level where I'm like, oh, if you hit that number, you're going to feel good. It's going to be low in menopause. We use it more if we're, fertility, things like that, trying to figure out if somebody is ovulating. You check at day 21, and if it's spiked, that's kind of a good indicator that somebody is ovulated. Testosterone is kind of a little bit different, because if we're thinking about doing testosterone replacement, so we'll use that in patients that have low libido, I like to get a baseline testosterone to just kind of see where they are in space and time. Do they have a low testosterone level to begin with? In my experience, most women do. And again, we don't have like reach this testosterone level and your sex drive will be great. You'll be, humping everybody that walks by. That just doesn't work that way. But in combination with like administering the testosterone, kind of looking at a patient if they're having any side effects, I kind of look at the level to just kind of be like, where are we? Did we go totally off the curve, or are we in like a semi-reasonable level? So those are just some of the labs that we might look at. And again, I know it's such an annoying answer. It depends on the patient. It depends on the individual. I always want to slap someone when you ask a question and that's the answer you get, but it very much depends in these situations.
I think that's the case for most of pelvic health and women's health.
Yes.
And even men's health.
Yes.
Like, the data and the certainty around PSA levels is very uncertain. It's always changing. So I think that's really valid, and that's why it's important to have that dialogue. And from what we're hearing now, it sounds like we can all save our money and our copay and our insurance on the labs, and allow our exquisite practitioner to listen to us and to manage us based on the symptoms. And if we're not getting managed, and if the conversation does drop, as you said, it's time to find a new provider.
Exactly. And you can absolutely save your money on like salivary testing and urine testing. There's like the Dutch test. They're wildly expensive. Again, maybe someday we will understand things more and be like, oh, this is useful now. But especially the Dutch test provides so much information that we have no idea how to even translate that sometimes into real, like, what do we do with this? What does this offer us? And it's usually like you have to pay a couple $100, but the outcome is the same. You end up on your hormone therapy, or, that type of thing. So again, I like labs as far as if I need help kind of figuring out what to do next, but nobody should be pressured into spending hundreds and hundreds of dollars for, customization of, these are personalized hormones only for you. Like, I don't know. We don't need to do that. We can do it much cheaper.
And probably with better results.
Probably. Most likely. Yeah. And as far as other labs, patients might want to be getting that have nothing to do, I don't want to say have nothing to do with menopause. That actually very much does, but not hormones necessarily. Like, getting your lipids screened every year. What does your cholesterol look like? Because that can absolutely change in menopause. With patients that have fatigue, looking at a CBC, do you have anemia? Is your ferritin low, like your iron stores? Looking at hemoglobin A1C, which can look at your blood sugars over the course of 3 months. Are you, at risk for developing diabetes? Thyroid function. That's a huge cause of, issues with temperature and weight changes and energy levels in women. So common in women to have thyroid dysfunction. Looking at your vitamin D levels, B12, all that kind of stuff could potentially be important. And sometimes it's something as simple as that, like, oh, your thyroid has gone off track, and adjust that, you're good to go.
Absolutely, because a lot of those symptoms are very similar to perimenopause, as you just touched on, with the energy levels and temperature sensitivity and um, whatnot.
Absolutely. I know. It's a lot of, I could cause this. I can also cause this. Now we're all like, which one is it?
That's wonderful. Thank you so much for shedding light on this and saving people money and saving their insurance copays and saving them the heartache of feeling crazy because if they test at a certain point when estrogen levels are fine, when they sweated through their sheets last night,
Mm-hmm.
be very frustrating. And
Absolutely.
is there anything else you would like people to know?
Hmm. That is an excellent question. I can't think of anything at the moment. No, just the biggest thing, like I said, is if you you ask someone, because that's usually the way I think most patients approach it is, let me get my levels checked. That will tell me what's going on. So they go to the doctor, the nurse practitioner, and they ask for levels checked, and it's immediate like, eh. And if you're not getting that response, then your next question should be, so what do we do next? What should I do about these symptoms? And if that doesn't open up the conversation, again, if you're meeting a brick wall, time to find somebody else, which I'm sorry, because that should not be your job, but that is unfortunately a common scenario.
Absolutely. Absolutely. We're always reminding patients to have to self-advocate, but to not give up.
Mm-hmm. Absolutely. Somebody's out there. It's like dating.
Find the practitioner that's your soulmate.
Where are you? Where are you out there?
Well, thank you so much, Andrea. We will be back here again next week. Our schedule is a little bit off for the next couple of months as we both have exciting things that we're going to be up to and
Very
doing.
exciting.
Clinical changes. So we'll be back here, same bat time, same Andy Mandy place, and we will be discussing another topic in hormone therapy. It's on our list. We will
It
check
is.
it. We will announce it.
We will.
And for those listening, if you have a topic that you would like us to cover, please don't hesitate to put it in the comment section or DM one of us, and we will discuss it because we are here, Andy and Mandy, to discuss vaginas.
We absolutely are. Please tell us what to talk about. And next time, I should have new
Oh,
wallpaper behind me.
is it
Very
vulvas?
special. You're going to have to wait and see. Tune in next time on Andy and Mandy to find out which wallpaper Andrea got.
I can't wait. Have a good rest of your day.
You too. Bye.
Bye.